Go ahead, Kathleen. You're muted.
That might help. Thanks, Amy. We'd like to welcome everybody to our February 2023 session of our Erie County Workforce Collaborative Training Series. The Department of Mental Health is happy to be able to offer these trainings to all of our providers in our community to support workforce retention and provide opportunities for individuals from our provider community to share their expertise. Today, we are excited to have Emma Fabian, Associate Vice President of Harm Reduction at Evergreen Health, to talk with us about prevalent drugs used in Western New York. At the end of this session, we will be asking everyone to complete a very brief evaluation. If you are interested in also receiving CEUs, please complete this evaluation along with your contact info at the bottom. It has name, email address, license information on there. Everyone will then be emailed a survey from Evergreen, which you will also need to complete. Emma will be processing those and will also be sending out the certificates for those of you who are interested in the CEUs. In March, we are happy to announce that our topic will be the art of talk therapy, development of your therapeutic style, and our presenter is Chris Fragan, LCSW. We will be putting the link for this registration in the chat at the end of this session. We will also be sending out our announcements, or you can always go to our erie.gov/mental health website for announcements and registration information for all of our trainings. Most of our sessions are offered on the fourth Tuesday of the month from noon until 1, and we'd encourage you to mark your calendars and watch for notices for future events. All of the presentations and recordings for our past offerings are posted on our website as well, so we'd encourage you to check those out. This is a community collaborative, and we're always looking for volunteers to share their expertise with our community of providers. If you are interested in doing a 1-hour presentation, or if you know someone who might be interested, or if you have a particular topic in mind that you would like to learn more about, you can indicate that on your evaluation, or you can email Amy directly at amy.rockwood@erie.gov. Our training today is being recorded, so everyone is muted. So if you have questions, please put them in the chat box. We will be monitoring the chat during this presentation, and Emma will be answering questions as we go. As always, thank you for joining us today, and I'd like to introduce Emma Fabian for her presentation on prevalent drugs used in Western New York. Thanks for joining us, Emma, and I'll turn it over to you.
Thank you so much. We are going to jump right in because we have a lot of interesting material to tackle in our time together. My name is Emma Fabian. I am a social worker by education, and I'm the Associate Vice President of Harm Reduction at Evergreen Health here in Western New York, which is a role that I love and that I consider myself privileged to have. And I'm happy to be here today. I'm calling in from the back of our syringe exchange program in downtown Buffalo, where my office is and where I spend most days. I'm also a part-time instructor at the UB School of Social Work. And so I enjoy talking about harm reduction as a response to the overdose crisis and substance use in general. And I never really thought I'd say this, but I love talking about what the most prevalent drugs are in Western New York, because I think it can really help us meet people where they're at and keep people safe and hopefully save lives, which is, I think, something that probably drove us all to be in this training this afternoon. So thanks for being here, and thanks to Amy and Kathleen. The whole Erie County Department of Mental Health and the Erie County Department of Health are such tremendous partners. I certainly wouldn't have all the contacts and partnerships that I have in Western New York if it weren't for them holding spaces like this. So thank you for that, and thanks for having me today. We are gonna move along a little bit. A little bit about Evergreen Health is we are a federally qualified health center lookalike with offices in Buffalo and Jamestown, and with some mobile services and care coordination across all of Western New York. We were founded 40 years ago as AIDS Community Services. Obviously, at that point in time in the 80s and 90s, we were doing quite different work. We were a smaller organization tasked with linking people with what available medical care did exist for HIV and AIDS, helping people, unfortunately, with end-of-life care, and also doing some prevention education in the community. Harm reduction, our roots in harm reduction really go back to that time in the 1980s, and we have continued to keep harm reduction really close to our mission. And right now that calls us to work a lot with people who use drugs, because that is one of the biggest crises of our lifetime right now is drug overdose. So a little bit about the material that we're going to cover this afternoon together. Why are we talking about what the most prevalent drugs in Western New York are? After our time together today, we hope that folks can have a deeper understanding of what the most common drugs in Western New York are and why people use them. So you'll see that we actually have some anecdotes from people who have used the substances that we're talking about today. And then we also want folks to begin to identify why it's important to have knowledge about these drugs in the context of behavioral and physical health care. A little bit more context. I mentioned that a big piece of our mission at Evergreen Health is the public health approach known as harm reduction. Harm reduction is also, I think, becoming, thankfully, a slightly more emphasized, acknowledged, embraced, mainstream public health approach when it comes to serving people who use drugs. I think particularly here in Western New York, we're a little bit ahead of the curve in terms of our embrace of harm reduction, which is a wonderful thing, and I'm happy to be able to say that. One of the core tenets of harm reduction has always been, this isn't new, one of the core tenets of harm reduction has always been recognizing that people have reasons for their behavior, and it usually involves coping and adapting. So even when we think about people using drugs, want folks to keep in mind today, while we're moving through the rest of this material for about 50 minutes or so, that people have reasons for using drugs, and it usually involves coping and adapting. So that's one of the things that we want to keep in mind. And then the second thing that we want to keep in mind is why really we want to have basic knowledge about the drugs that are available in Western New York. First of all, as behavioral health providers, as physical healthcare providers, as friends and family members of people struggling with substance use, having basic knowledge about what drugs are available and why people use them helps us assess and discuss risk with our patients. It also helps us remain non-judgmental and unsurprised when discussing substance use and mental health and all the things people have to do to survive when they are struggling with substance use and mental health, and allows us to, as objectively as possible, discuss options with them. Last, it helps us assist them with relevant harm reduction resources that a patient can utilize. When we understand why people use drugs and what the impact of those drugs are, in a lot of cases, we're going to come to the realization, although we might want this person to stop using so that all reduce can be eliminated, it's probably not that simple. It's probably not that simple as telling someone who's alcohol dependent to just stop cold turkey and be abstinent. Same with opioids, same with a lot of other substances. And I think so it's important for us to have this education, because then we can tailor treatments and interventions that meet people where they're at. So what we're going to do here with the time that we have left this afternoon is we're going to move through a whole range of different substances, starting with prescription opioids. Then we're going to move into talking about heroin. Then we're going to move into talking about fentanyl. Those are some really important ones for us to have an in-depth understanding of. But then we're also going to talk about a few different stimulants: benzodiazepines, MDMA, xylazine, alcohol. We're going to talk about this whole range of substances, and you're going to see, if you're watching the shared screen, on the left hand side of the slides, I'm going to start by talking about just some factual, in some cases commonly known information about different categories of drugs. And then on the right hand side, I'm going to share anecdotes from people who have lived experience using these substances, either currently users or formerly users of the substances, what they say about the drugs and what their peers, people in their network, say about why they use drugs. If you're confused a little bit, stay with me because it's going to make sense once I get started. So we're talking first about prescription opioids. Why are we talking about prescription opioids first of all? Well, because the first wave of this overdose crisis that has really tragically hit the United States and Western New York quite hard, the first wave of the overdose crisis began with prescription opioids. For the most part, this spike in overdose deaths. Think about the time of the late 90s, early 2000s, our healthcare community became inundated with education and encouraged to prescribe opioids at that time. And we saw a far greater amount of prescription opioids in our communities in the United States than ever before. So that's why we're starting there. If you watch television or if you read magazines or whatever, digest some pop culture information about substance use, you might end up with this myth in your mind that the only reason for the overdose crisis that we're within right now is because prescription opioids hit the scene and doctors and prescribers were really encouraged to prescribe them. I do think that that is one piece of the puzzle. That is one factor contributing to the overdose crisis, but there is a lot more to the story. Substance use and addiction is a complex combination of biological, psychological, and social factors. Only one element of that is the rise in prescription opioids, but it's an important one. So what are prescription opioids? Well, we're talking about opioids that are used to prescribe, treat, moderate to severe pain. How do they work? Well, basically, a lot of us know this by now. Opioids work by binding to certain receptors in our brain and body, blocking pain signals, and ending up with the release of dopamine. They can be incredibly effective at treating physical and emotional pain. So it's no surprise, really, that we saw this rise in prescribing opioids when more strong opioids became available. If taken in high amounts, prescription opioids, again, taken in high amounts, can cause people to feel extremely relaxed, euphoric, maybe even what we know of as high. The most common prescription opioids are things like codeine, hydrocodone, oxycodone, Lortabs, Percocets. Those are names that a lot of us are familiar with these days. Probably, I think should be used to treat very severe pain. And I think some of the things that we're correcting nowadays in our culture are like, do we need to prescribe like 30 Lortabs for somebody getting their wisdom teeth pulled? And then when they call and say that they're out of Lortabs, just writing another script. That's an exaggerated example, but like some of these practices have definitely been checked, especially here in Western New York and Erie County. Whether or not that's leading to people who have legitimate chronic pain not getting the prescriptions that they need to treat pain, I'm not really here to debate that today, but I think in some cases we're hearing about some unintended consequences in the cutting down of prescribing opioids. And then I already mentioned how early in the overdose crisis, the first wave of the 3 waves of the overdose crisis, really, we saw a lot of people initiate substance use with prescription opioids. Now, unfortunately, data shows in this day and age that more people are initiating with other illicit substances. It doesn't always begin just with prescription opioids anymore. From people who use drugs, they've told us, especially in a certain age group, that in a lot of cases, they started using with prescription opioids initially and then switched to other illicit or street drugs. Illicit, street drugs, illegal drugs, I'll use those terms kind of synonymously. Interesting to note, what we have heard a lot from people in the past 10 years is that prescription opioids now are incredibly expensive to buy on the street illicitly and very hard to find. So most people are not buying them on the street anymore, especially as much as it maybe used to happen 15, 20 years ago. We're going to move on now that we've covered prescription opioids into talking a little bit about heroin. Heroin's a naturally occurring opioid, a naturally occurring substance found in poppy plants. It has been for decades the most popular street sold opioid in the United States. Probably for us here in Western New York until fentanyl hit the scene in like 2015. Heroin, of course, the routes of administration can vary. People can, and routes of administration refers to how we consume substances, right? When we're talking about prescription opioids, most people are taking them orally or crushing them and snorting them. With heroin, it's often smoked, sniffed, or snorted and injected. Injecting heroin here in Western New York, unfortunately, is quite popular. And oftentimes the route of administration increases risk. Okay, so the rush that one feels from injecting heroin can be more severe, pleasurable, euphoric, at least initially, than the other routes of administration, but it can also be a lot riskier, especially if you are using something that could be cut with fentanyl. Heroin now is used in other countries for pain and occasionally addiction therapy. The closest to us here in the United States would be in Canada. There are heroin-assisted treatment programs, and then also Dilaudid assisted treatment programs. Chemically, Dilaudid and heroin are very similar chemically. So from people who use drugs, this is what folks have told us about heroin. It can create a feeling of warmth and relaxation and detachment, can lessen anxiety and emotional aches and pains. And heroin's often referred to as dope. So usually in Western New York, when you hear someone say the term dope, they're talking about opioids. They're not talking about stimulants. So think when you hear people say dope, think heroin, fentanyl. It's kind of an old school term for opioids, street bought opioids. Heroin, for better or for worse, is also thought of as a hard drug, as opposed to a lot of folks think of things like alcohol or marijuana, even cocaine in some contexts, as not hard drugs. Most folks initially use heroin for euphoria or escape initially, but then become physically dependent. And the way that a strong opioid like heroin binds to our opioid receptors is that once our body develops a dependence or a tolerance, we have to use a certain amount to not feel sick and not feel in withdrawal. That's, the basics of dependence and tolerance when it comes to opioids. Right now, unfortunately, in Western New York, it's hard to find true heroin, even though if you are out in our community, you might hear people using the term heroin or dope, or ask someone what their drug of choice is. If you're in like a treatment setting or a healthcare setting, people often still say heroin or say dope. What we know is that most dope bought on the streets in Western New York, especially here in Erie County, is fentanyl. There was a statistic released recently, I believe, from the Erie County Department of Health, and I could get this slightly wrong, so I'm sorry because I'm not looking at it. I'm not looking at the data in front of me, but I believe something like 92% of opioid overdoses in 2022 had quite a bit of fentanyl, a significant amount of fentanyl in them. So we can assume from the data, we can get from the data that it is fentanyl that's leading to the very high rates of drug overdose here in Western New York, but also much of the United States right now, where every year more people die of unintentional drug overdose than ever before. And it's the leading cause of death for people ages 18 through 45. Okay, so moving on a little bit to fentanyl, this really popular kind of, or I shouldn't say popular, but this, very talked about substance right now, even if you're not in the healthcare or behavioral health field, right? So what is fentanyl? Well, it's a synthetic opioid. So whereas when we are talking about heroin, we're talking about something that's derived from a natural plant, fentanyl is synthetic. It's made somewhere in a lab. It's not naturally occurring, and it's used to treat very severe pain. In fact, prior to like before the past 10 years, probably in Erie County or Western New York, if you were talking about fentanyl, what people would call to mind was this idea of fentanyl patches that are used to treat, kind of like a gel-like substance in a patch, used to treat incredibly severe pain. It's been used to treat incredibly severe pain because fentanyl can be as much as 50 to 100 times more potent than morphine. It's a very strong opioid. It's fast acting, and it's got a shorter life than I'm having a loss for words, but it's faster acting and lasts less time than something like heroin. It quickly depresses our central nervous system and can quickly impact our breathing and thus our heart rate. And we know, in the field, of course, that is what half-life. Thank you. I almost said shelf life, which is like a food thing, not, but half-life. Yeah. The half-life of fentanyl is less than something like heroin or especially some of the prescription opioids we were talking about. It acts quickly. It's got the ability to quickly impact the central nervous system and breathing and thus our heart rate. So we know that that's what leads to overdose. So fentanyl's ability to put people into an overdose very quick is very, very significant. That's why, unfortunately, we've heard a lot of cases about people suffering fatal or non-fatal overdoses and being found still with a needle actually in their arm. It's got a higher potency. It's lower to cost. It's a lower expense to produce fentanyl. Just think, not to get too much in the business of the whole thing. I know people constantly want to say, well, why would we, kind of cut our illicit drug supplies of all of these substances with fentanyl? And I don't want to get too much into that today because I want to talk about why people use substances and what effect they have. So because our goal here is to really talk about how we tailor interventions that meet them where they're at. But I think it is worth noting that because this is a synthetic substance, it can be tweaked a little bit and not detected by drug screens or by other tools that like law enforcement might be using. But it can also be made in a lab. We don't need to, there's not like a finite amount of it because it comes from naturally occurring plants. Recently in Western New York, and specifically here in Erie County, where I think our Erie County Health Department does a good job of tracking data and getting it out to the community, is there's a clear trend in fentanyl and stimulants in overdose deaths. And there's a lot of evidence and also anecdotes from people who use that suggest that fentanyl is in the supplies of illicit stimulants like cocaine. That's scary. That's a game changer for recreational substance use. Fentanyl has probably changed the landscape of illicit drugs for good. If stimulants are laced with fentanyl, it's particularly dangerous because people who use stimulants, they might not be already inundated with the harm reduction tips that opioid users are accustomed to now, like never using alone, having Narcan on you at all times, taking a test shot. Those basic harm reduction tips, folks who use stimulants aren't expecting to find these really strong synthetic fentanyl derivatives in their cocaine. So the risk of overdose is really significant. Also means that people might be unintentionally consuming fentanyl and they are not typical opioid users, so they don't have that really strong dependence and tolerance to fentanyl. If someone who doesn't have tolerance and dependence to fentanyl uses fentanyl, the risk of overdose is incredibly high. From people who use drugs, they in fact reflect the same sentiment that the high overdose rates in our communities are because of fentanyl. It's a quick and intense, short-lived high. That means people have to use more frequently. People are encountering it, but not necessarily looking for it. I think there's a little bit of a myth that like When people hear about really strong fentanyl somewhere, everyone flocks there, even if it is contributing to overdoses. I don't think that that's as simple. It's not necessarily as simple as that. A lot of folks wish that there was just pure heroin available in Western New York. Tips for fentanyl, this is something that anybody who uses any type of substances in our system, or just someone who has friends and family members that use substances, should all be aware of the tips about reducing risk of a fentanyl overdose. Not using alone, using less at a time, which is often known as taking a test shot or using less at a time, having Narcan available, and having these tools called fentanyl test strips, which a few years ago you couldn't find anywhere, and now they're almost everywhere. In fact, I thought I had some on my desk here. Fentanyl test strips are just, this intervention where people can, on their, out in the community, can use a tool to test whether or not fentanyl is in what they're about to use or what they've bought. Honestly, some folks are saying it might be almost a waste of time and a resource to be testing dope these days, because you can be pretty sure that fentanyl is probably going to be in any street bought opioid. But it's still a very helpful intervention. I think it's empowering. It provides some autonomy to users. And I think I really recommend anybody who's even using cocaine, methamphetamine, anything illicitly bought benzodiazepines to have fentanyl test strips. Moving along a little bit to benzodiazepines, also known endearingly as benzos. Benzodiazepines are a class of drugs that are commonly used, commonly prescribed by primary care providers, psychiatrists, and other psych providers for anxiety and panic attacks. Benzodiazepines, one of the ways that they're effective is by depressing our central nervous system, and that can slow breathing, especially when taken in high amounts. Now, remember, that is also a potential symptom of using opioids, and I'll return to that in a moment. But when someone uses benzodiazepines that might not be prescribed to them or uses them in high amounts, it can look like being very sedated, sleepy, but it can also look like somebody who is typically pretty anxious, has no anxiety at all, is very relaxed. It could increase the risk of overdose when used with opioids. And this is, I'm not going to get too much into the neurobiology or chemistry of it, but it's basically because of the potential to really act on our central nervous system, and if taken in high amounts with opioids, and slow breathing, and then, of course, eventually slow down the heart rate and stop the heart. In fact, several years ago, there was a black box warning issued by the FDA on co-prescribing methadone and Suboxone, those gold standard treatments for opioid dependence, to anyone that also had a prescription of benzodiazepines or had toxicology screening that had benzodiazepines in them. So there used to be this black box warning. Black label warning, black box warning. Clearly, I'm not getting my terminology great today, but that warning has gone away to an extent. I mean, I know it's still something that's certainly on providers' minds, prescribers' minds, should be on our minds in behavioral health and in the healthcare system in general. However, in light of this overdose crisis that our country is dealing with, I think most have ruled that we don't want to have too many strong warnings preventing people from prescribing buprenorphine, because buprenorphine can be such a valuable tool for decreasing overdose risk. Common names of benzodiazepines, you all know it: Xanax, Valium, Ativan. There's some other ones. Xanax tends to be either bought on the street or prescribed, quite a common benzodiazepine. Benzos are different from SSRIs that are also prescribed for anxiety and depression. SSRIs not commonly misused or sold illicitly on the street. From people who use drugs, I admit before I came to work in the field of harm reduction, I didn't know that benzodiazepines had like a street value or were commonly misused. But for folks, especially who like the effects of alcohol or opioids, this is just my experience, tend to also have some experience using benzodiazepines. Not always, but in a lot of cases, because they can lessen the feelings of anxiety, take away stress, and take the edge off, can cause memory loss, especially if taken in high amounts. So when someone has taken a significant amount of benzodiazepines, whether prescribed or bought on the street, there is a significant possibility that they're not going to remember what happened when they were under the influence of those strong benzos. Can have a similar feeling to alcohol. This is an interesting one. In Western New York, especially Xanax is often sold on the street under the name bars or pins. And that's because like the most common form of Xanax that gets diverted is bought like a long pill that can easily be broken up into pieces. Usually when a provider is prescribing that, there's good reason for it, why they could be broken up into pieces. But it also makes it pretty attractive to the illicit market or to the street market. They can have a synergistic or intensifying effect when used with heroin. So they can intensify the feelings of using opiates. Moving along a little bit to crystal methamphetamine is something I think that we're talking a lot about right now in behavioral health and healthcare in general. Crystal methamphetamine is chemically a cousin to amphetamines like Adderall. In fact, I've heard especially in the past 5 or 6 years, that folks who feel like they have either been diagnosed with ADHD or ADD in their lifetimes, or they just feel like they have the symptoms, even though they haven't been formally diagnosed before, really find that crystal methamphetamine helps them function. The effects of crystal methamphetamine, depending on the route of administration, the frequency of taking it, and how much is taken at a time, can on average last between 4 and 8 hours, which is quite a significant stretch of time, especially as compared to other popular stimulants. Historically, methamphetamines were interestingly prescribed for a variety of reasons. The literature demonstrates that it's been prescribed for narcolepsy, depression, ADHD, like I mentioned, and weight loss even. Crystal methamphetamine basically increases wakefulness and activity and can decrease appetite. Prolonged use can lead to sleeplessness, appetite loss, mood swings, aggression, and something that we are seeing, I think, a lot in our community in Western New York in the past couple of years, particularly since 2020 and COVID-19, probably for a variety of reasons, is methamphetamine-induced paranoia, psychosis, and hallucination, especially when people are coming down from binges. So not just using once, but using every 2, 4, 6, 8 hours. Coming down from that meth use can look a lot like substance-induced paranoia, psychosis, or hallucination, and can be a challenge for a number of reasons, one of which being it's hard to know how to assist someone because there's not a ton of research on treating methamphetamine, but also because the symptoms can look a lot like severe mental health. And so if you don't know a person, it's difficult to know exactly what they're struggling with. Another thing about crystal methamphetamine, it can heighten the intensity and duration of sexual experiences and lower inhibition. I think there seems to be a slight typo on the screen at the bottom. Sorry. I think the last bullet point is cut off, or maybe there was like a trouble converting the formats or something. But that's the factual information about crystal meth. Moving on a little bit to what people say about using crystal meth is on the street, it's often referred to as ice, meth, tea, or Tina. Crystal meth is often referred to under those nicknames. Folks say, like I mentioned before, that it can be helpful with symptoms associated with ADD and ADHD. Some people describe it as similar to Adderall, but obviously way more intense. Chemsex, a term that we are understanding, I think, a lot more about in recent years, or talking a lot more about in healthcare than we have before, has to do with using substances such as crystal methamphetamine to heighten sexual experiences. That's where we get the term chemsex from. And in New York State, and a lot of the United States, but here in New York State, we're seeing that crystal methamphetamine is the drug of choice in a lot of circles among individuals who engage in chemsex. On the other hand, folks who are using it more recreationally, not necessarily associated with chemsex, find that it can help them be productive and gives them energy. There's not a ton, so people who use drugs have shared in recent years that they feel like sometimes crystal meth use is left out of conversations about drug treatment. I can't say whether or not, I don't have necessarily like a judgment on that statement, but I guess I can see where people are coming from. We don't, have public service announcements about the dangers associated with crystal meth use. It tends to be a pretty stigmatized substance. And I think we haven't yet embraced medications used to treat crystal meth dependence or addiction or use disorder, basically, in the way that we have embraced medications to treat opioid dependence or alcohol dependence and other types of substance use disorders. So I think that's interesting, and I think people who struggle with meth use recognize that. While there for sure are a range of types of therapies, including just basics like CBT or DBT, some of the more popular models of doing therapy and counseling can certainly be applied to folks who use crystal meth. But I think people still have a point when they point out that we really don't talk a whole lot in treatment settings about treating crystal meth use. Moving on a little bit to cocaine, I want to point out, whether referred to as crack or powder cocaine, these are the exact same substances. Cocaine, whether it's in the form of crack or just plain powder cocaine, is a stimulant drug sourced from the coca plant grown most notably in the Andes Mountains. So this is another naturally occurring substance. There is no pharmacological and there's no chemical real difference between crack or powder cocaine. The only difference is in how it's taken. Often crack is smoked because crack is a term for cocaine that's been mixed and cooked down a little bit with baking soda to form rocks. So it is convenient to smoke. Whereas cocaine is frequently snorted or sniffed, or in some cases injected. Cocaine has a short half-life. Cocaine's got a short high, depending on how it's been taken in terms of the route of administration, how much was taken, but it's generally, we're talking a pretty short high here, between 10, 15, 20, 30, or maybe a little bit more minutes. It provides feelings of alertness, power, and energy, and can give folks confidence. One of the reasons why I pointed out that there's no pharmacological difference between crack cocaine and powder cocaine is because I think cocaine is a terrific example about how our social kind of societal or cultural understanding of this substance has been very much shaped by laws and regulations and media that we have digested about the substance. Historically, there are very large disparities in criminal penalties for crack cocaine versus powder cocaine. One of the best examples of this type of policy is the anti-drug abuse laws, also known as the Anti-Drug Abuse Act, which is like a package of bills turned into law in the late 1980s, that in some cases it spelled out incredibly stiff criminal penalties, even mandatory minimums for the possession or intent to sell crack versus much lesser criminal penalties associated with powder cocaine. I think that's just important to take away. And if you're interested in learning a little bit more about that phenomenon, there is an interesting documentary, I think available on Netflix, at least it originally was, called Crack, C-R-A-C-K. Great documentary that talks about the effects of cocaine, but also the historical coverage and policies and regulations and laws that have really helped shape our understanding, not only of those substances, but have created a great deal of stigma surrounding the use of crack in the United States. Cocaine is often, powder cocaine especially, is often considered a soft drug, especially among people who use drugs, whereas a lot of times like heroin and fentanyl, opioids are referred to as hard. People who use drugs recognize that crack has a terrible stigma associated with it. And again, I think that at least has some to do with the laws and policies that our country has placed on people who use crack or have intent to sell crack. In fact, we've been told that one of the worst terms that you can be called by even another substance user in our communities is the term crackhead. And that makes me sad, you know, to be honest. I think when we think about the relative harms associated with drugs, gosh, when you just kind of take all of this in kind of a big picture sense, it's unfortunate that a lot of our understanding of drugs and even the available treatments for certain drugs and the criminal penalties around drugs have been shaped not necessarily really based on the chemical effects and why people use substances or the relative harm associated with them. It's got a short-lived feeling, so you have to keep using it. Prolonged use of cocaine can cause paranoia and anxiety. Some would say that's got to do with how it affects neurotransmitters chemically in our body. The effect that cocaine has on dopamine. Once you use cocaine for a prolonged period of time, if you stop using it, folks can say just like a lot of depression, anxiety, and paranoia is something that they can feel.
Emma, we do have one question that came in, so if you have a minute. Someone asked, chemsex in some circles has been used to talk about sex relations between men. Is that more prevalent with meth?
I would look up this documentary called Party Boy, P-A-R-T-Y space B-O-I. Party Boy is a really good documentary all about the use of different substances in the MSM community. I'm really not an expert. My feeling is yes, chemsex is more prevalent, but I don't want to say that because I'm not an expert on that in particular. My feelings, yes, I would look it up. Sorry, I don't have a better answer.
Thanks.
Look up the documentary though. If you're at a computer, which you probably are because you're watching this right now, Google Party Boy, really good documentary. I think you can watch it even like, I think it's readily available, like a lot of documentaries about substance use are right now. I've watched it a couple times. We actually showed it to staff at Evergreen a few years ago, just because it was very deep, very good documentary. So moving on a little bit to talking about alcohol. Alcohol is a drink that contains ethanol, which is basically a type of alcohol that's produced during sugar fermentation. There's a lot of variety in terms of different types of alcohol, because alcohol can be produced by several different fruits, grains, different types of substances. But the chemical effect of alcohol is that it acts as a depressant. It slows down thinking and actions. Binge drinking is commonly referred to as a significant issue in the United States. Binge drinking, when it comes to people who identify as women, means 4 drinks in 2 hours. Binge drinking for people who identify as men breaks down to 5 drinks in 2 hours. And there's a slight difference in how different bodies in general, to be honest, metabolize alcohol. Binge drinking, 4 drinks in 2 hours or 5 drinks in 2 hours, I will leave it up to you. In a city, a region where alcohol use is fairly common, do we really consider that a lot? How many people in our circles probably meet the criteria for binge drinking? I'll leave that, just for folks to ponder. But I think it's interesting to think about. Heavy alcohol use is defined as binge drinking on 4 or more days in the past month. Again, think about bill season. Think about when the Bills almost make the playoffs. No, I'm just kidding. It's really not a funny joke. But the point is, it's kind of a funny joke. I mean, the point is that alcohol is very widely embraced for celebration, socializing. It is associated with a lot of activities in our country and in our region in particular. Heavy alcohol use, which has some significant long-term health effects, is defined as binge drinking on 5 or more days the past month. Just something interesting to think about. High blood pressure, heart disease, stroke, liver disease, learning and memory problems, alcohol dependence are just some of the long-term effects of heavy alcohol use, fairly common in the United States. From people who use drugs, they point out, first of all, I think it's interesting. I know a lot of folks who have been illicit opioid and crack and cocaine users for many, many years, and say they would never touch a drop of alcohol. They don't like the effects of alcohol. But for a lot of our society, it's initially a way to relax or have fun. Often a way to relieve stress, to feel a little bit more confident in a social setting. But depending on how your body metabolizes alcohol, and also depending on the other biopsychosocial things that you have going on in your life, alcohol can also just make you feel more lonely or make you feel isolated, depending probably on why you're drinking, who you're surrounded by, where you are, how much you've consumed, that type of thing. For people who are alcohol dependent, there's a serious fear surrounding running out of alcohol. I think we think about this when we think about our people that are coming into treatment centers for alcohol dependence, and we suffer really big snowstorms in a place like Buffalo. Just think about the fear and the anxiety that can come along with not being able to have access to alcohol once you're alcohol dependent. Withdrawal from alcohol can be very painful and even lethal. Alcohol is not something, and we don't talk about this too much outside of healthcare and behavioral health, which probably makes sense, but alcohol, once you've built up a tolerance to it in your body, isn't something that is medically recommended that you just cut cold turkey. In a mild withdrawal can involve severe symptoms like seizures and other uncomfortable, but also just really unhealthy, poor health outcomes. It's not recommended that people withdraw from alcohol with not some medical oversight. Okay, we're in the home stretch here. We're just going to talk about a few more here. I think somebody asked the question, do we want to take a second to respond to that, or is it more of like a comment?
Comment that just came in saying the liquor stores stayed open during COVID due to the negative lethal effects of withdrawal.
Thank you for sharing that. Yeah, good point. Moving along a little bit to marijuana, something that's now decriminalized in New York State. When we're talking about marijuana, usually we're talking about a plant, dried leaves, flowers, stems, and seeds from the cannabis sativa plant or cannabis indica. Marijuana contains a psychoactive component known as THC. That's the component that makes folks feel high or euphoric, and then a non-psychoactive agent called CBD. Use of medical marijuana, as well as marijuana for recreational purposes, dates back a very, very, very long time, as long as 12,000 years ago. It was not criminalized in the United States until the early 20th century. In other words, the 1900s is really when we saw criminal penalties associated with marijuana. Some people suggest really that's the beginning of racialized drug policies. Medicinal properties for marijuana include treating pain, one we hear a lot, reducing nausea, another one, and stimulating appetite. Can be some effective medicinal properties there. And then there's some other ones as well that are specific to particular disorders. From people who use drugs, folks say yes, marijuana, weed as it's often referred to, can be excellent at treating acute nausea, pain, hangovers, and even withdrawals. In fact, sometimes we hear people who are trying to get off fentanyl and onto methadone or buprenorphine say that in the hours or day or a set of hours that they are going to not use fentanyl so that they can get onto a medication. Marijuana can be for some people something that lessens like the nausea and some of the withdrawal symptoms. Now we know withdrawal can be unique to an individual, but that is something that I've heard over the past few years as the potency of fentanyl has increased, but also the availability of buprenorphine and methadone for treatment. Access to that has increased as well. Marijuana is commonly used socially. It can be used in place of cigarettes, alcohol, or other drugs. It's often thought of, for better or for worse, as natural or low risk. It's just natural. Can both help or worsen anxiety. That's something that definitely depends on the person. It can be relaxing and help some people sleep. In fact, that's one of the reasons why a lot of people take CBD, which is, remove that THC psychoactive component. CBD can help with sleep. And some research does link heavy marijuana use with psychosis. Moving along a little bit here, we just got a couple more to cover. I'm going to move into MDMA, also known as ecstasy, X, or Molly. This is a psychoactive drug with effects similar to stimulants and psychedelics. It's got the ability to heighten sensations, but also heighten feelings of connectedness and really enjoying things. it basically impacts our brain by releasing lots of serotonin in a similar way that maybe you think of like cocaine's, the effect of cocaine is that it stops our receptors from reuptaking dopamine. So there's just a lot of dopamine available. That is kind of similar to how MDMA works by releasing lots of serotonin and temporarily inhibiting the reuptake of that. It's commonly cut with other stimulants now these days, such as amphetamine, cocaine, and ketamine. MDMA, there is a growing body of research that demonstrates it could have some use in conjunction with traditional psychotherapy for things ranging from anxiety and depression to other disorders as well. From people who use drugs, they've said that it makes you feel social and outgoing. It's a fun party drug. You can feel great during use of Molly or ecstasy or MDMA, but the come down can be psychologically and physically, but mostly psychologically, very difficult. It can induce feelings of severe depression and anxiety. Most people who use MDMA and want to really control their use of it in like social, music, festival, partying type of settings refer to wanting to find the sweet spot, which would be the dose that you take that you feel the positive effects, the outgoingness, the increased feelings of being connected to those around you, but don't have those negative effects. Therefore, some people microdose substances like this and other types of psychedelics. Take small amounts so that they can reduce the risk of overtaking it. Synthetic cathinones is something that we don't know a whole lot about. Most of the anecdotes and what we know about synthetic cathinones has come from first responders or emergency rooms where people have come in after taking synthetic cathinones. But these are basically something like euphoric stimulants that have a short-acting physical and psychological effect. They increase energy and alertness, and that way they're kind of similar to crystal meth, but also elevate mood, social ability, anxiety, and unfortunately paranoia. There's a significant variation among the symptoms and effects that folks have noted here in Western New York. Some of the effects that have been noted are things like things like an inability to control movements, and an inability to control the sounds, the noises that someone's making, and also have caused, in some cases, memory loss. But in other cases, people have noted that they cannot control their body movements or the verbal noises that they're making. Yet they are present and they do know what's going on, and they even remember what's going on. So that's a little scary. A couple names that we think are synthetic cathinones are flocka and also bath salts. And so there's been some acknowledgement that flocka and bath salts have been in Western New York. I don't think by any means they're like among the most common substances that people use. Those we more covered earlier on in our slides here. Usually people are not intentionally purchasing synthetic cathinones. It's being sold as meth or another stimulant or another psychedelic. The last substance we're going to talk about here is another one that unfortunately we don't have a ton of information yet about in Western New York, but we do know basically what it is, and that it's popped up in Philadelphia, New York City, and that it could eventually make its way here as something called xylazine. It's a pharmaceutical drug used for sedation. It's a tranquilizer, and it's mostly used for animals, not humans. It's similar basically to clonidine, which is an antihypertensive drug, but it's way stronger and longer lasting. As of 2023, we don't have medical confirmation or clinical confirmation of this being in Western New York's drug supply, but it's been found elsewhere. And because of the wounds and ulcers that have been noted in other places on the East Coast. We think that there could be xylazine in Western New York because some very severe wounds that have come up in Western New York could be associated with xylazine being present here. I'm going to wrap it up here and just say that we should look for more information on xylazine. We should be aware of the symptoms associated with it. We should be probably pushing the FDA to come up with a xylazine test strip so that we can really mitigate the harmful effects of xylazine. One thing that we hope people take away from this presentation is just thinking about the relative harms associated with the drugs that we just moved through, the widespread use of alcohol, the long-term negative health effects associated with use of alcohol and some of the more prevalent substances versus what we commonly think of as hard or very dangerous substances. And how our substances, the way that we perceive drugs, even in the healthcare community, often is tied to the media's portrayal of substance use and the people who use those particular substances, and our policies and regulations and laws aimed at the possession of certain substances.
Great. Oh.
I'm going to end it there, actually. Take a look at the final takeaways that we have up on here on this final slide, and look out for the post-training surveys coming, especially, not only, but especially if you are someone who's going to receive continuing education units for attending.
Thank you so much, Emma. That was great. And I've posted 2 things in the chat. The first link is to our evaluation, which again, just like Emma said, please complete that evaluation, especially if you're looking for CEUs. It has information on the bottom that we will forward to Emma, and you'll be receiving an evaluation from them as well, and then your CEU certificate. I did also post the link to register for our next session, which will be in March. The recording of today's presentation will also be posted to our webpage within the next few days. So again, erie.gov/mental health. If you are interested in being a presenter, again, please let Amy know, or if you have ideas of topics you'd like to learn more about, we'd like to hear that too. And again, thanks Emma for such a wonderful presentation. Thank you all for being part of our collaborative. And any final questions, feel free to type in. I didn't see any else that came in, but feel free to put questions in there if anyone has anything, and we can follow up.
I'm going to unshare my slides at this point. That's okay.
Sure. We did get one question that came in just a minute ago. Any chance you can go back to the second to last slide? I'm not sure which one that one was.
I think I saw that little comment come through, and I think we're on the second to last slide at this point.
Yeah.
Unless they're referring to xylazine, in which case I can also go back to that.
A lot of great comments coming in, thanking you, and obviously I'm a lot of people that you've worked with over the years, and very informative comments that have come in.
Awesome.
I'm going to stop the recording now. Thanks, everybody.